Hello, everyone. Thank you for joining us today for our webinar entitled Advancing Care Information and Meaningful Use in 2017. Today's presenter is Bruce Mackey, MCEDA's Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's webinar and a copy of the presentation slides on our MCEDA website at www.mceda.org/GLPTN. Also, the presentation slides are currently available in the Handouts section of your GoToWebinar interface. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since Medicare and Medicaid policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Today, Bruce is going to provide you with everything you need to know about participating in meaningful use and the Advancing Care Information Performance category of the Quality Payment Program in 2017. Following the presentation, Bruce will take time to answer any questions posed by the attendees. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you, everybody, for joining me today while we discuss the Advancing Care Information Performance category of MIPS and meaningful use in 2017 and what it means to be participating in both programs at the same time. So we'll start off. I've got my glossary of acronyms here for any of the multitude of acronyms I'm going to be throwing at you throughout this presentation. If any of them don't make sense, you can refer back to this slide and figure out what I'm talking about. All right, first off, let's talk about eligibility between the two programs and how they are different and how they are similar. So we've got the eligible providers on the Medicaid meaningful use side on the left here, and the eligible clinicians, terminology change in the program, in MIPS or in the Quality Payment Program. So under ACI, there are some striking similarities. Everything that's above the red line here on your slides are identical, as you can see. In both programs, the eligible clinicians are, eligible providers are the MDs, DOs, the dentists, we've got doctors of optometry, and nurse practitioners. Those are identical between both programs. From there, anything below the red line, we start to shift a little bit. We've got some differences in eligibility. So on the meaningful use side, we have physician assistants that are practicing in a PA-led FQHC or rural health clinic. So by PA-led, that means that the PA is in a leadership position in the FQHC, might be an owner, could be the managing physician or the lead physician. It could also mean that in a 90-day period, the PA has seen more visits than any of the other physicians, any of the MDs or DOs in that FQHC. That could also deem the FQHC a physician-led FQHC, and therefore the PAs in that FQHC would be eligible for the program. A lot more straightforward under ACI. All the physician assistants are eligible for the MIPS program. Also on the Medicaid side, we have certified nurse midwives. At this time, the midwives are not eligible clinicians under MIPS. I believe we will see them become eligible clinicians in a couple of years, probably by year 3. But for years 1 and 2 anyway, nurse midwives are not eligible for the MIPS program. So additionally then, if we look on the right-hand side here under ACI, we also get chiropractors, clinical nurse specialists, certified registered nurse anesthetists, and doctors of podiatry. Those are all also eligible clinicians under ACI, but they are not eligible providers under Medicaid meaningful use. Some additional requirements to take a look at on the meaningful use side, because the Michigan Medicaid program is, or the Medicaid meaningful use program is the only one that's alive and well. We do have to consider that 30% patient volume That is a requirement to get into the game. So over a 90-day period, you have to take a look at all of the patients you saw in that 90-day period, and at least 30% of them need to be Medicaid patients. It doesn't mean that you necessarily build Medicaid for that service. It's just that the patient is a Medicaid program or a Medicaid insurance holder. Also, for pediatricians, that is not a 30% patient volume. It is a 20% patient volume, but it only pays if the pediatrician is only reaching that 20% volume, then they're only going to get 2/3 of the incentive payment. So each year that incentive payment, other than the first, not counting the AIU payment, each successive payment is $8,500. So they'd only be getting 2/3 of that if they're not reaching that 30% patient volume. Also, I want to point out that that 20% variation is not attributed to nurse practitioners in the peds clinic. That only works for the pediatricians, for the MDs and DOs. On the ACI side, we've got something called the low volume threshold that could be used to either opt into the program or potentially used to opt out of the program. But it takes a look at the Medicare physician fee schedule, Part B, allowable billing charges of greater than $30,000 and provides care to more than 100 Medicare patients in 1 year. So to opt into MIPS, to be able to participate in ACI, both of those have to be true for the provider. They have to have greater than $30,000 in Medicare Part B allowable charges, and they have to provide care to more than 100 Medicare patients in a 12-month measurement period. So if either one of those is not true for the provider, then they are not a MIPS provider. They cannot participate in ACI. The dates that they're using to determine that 2017 eligibility are September 1st, 2015 to August 31st of 2016. They are also doing a second look for the next year that is also attributable to 2017. So there's the second date check that they're going to use, again, to exclude more folks. If you've already been excluded based on that first eligibility check of September 1st, 2015 to August 31st of 2016, then you're excluded. You won't. The second check isn't going to push you back into the program. They're using a second check of September 1st, 2016 to August 31st, 2017 to exclude additional providers, meaning if there was not enough data in that first date range to accurately assess providers, for instance, anyone that's sort of new to the program that maybe joined after August 31st, then they're going to do that second check to see if those providers are eligible. Also, between April and May, CMS mailed letters to each practice. So each practice got a single letter, or they were supposed to get a letter, although we understand a lot of them didn't make it to their final destinations. But between April and May, CMS mailed letters to practices that detailed the MIPS eligibility information for all of the clinicians that are billing to their respective TINs. Again, we know a lot of those letters are lost. I don't have any great way to get a copy of that letter. There does not appear to be an easy way to get a photocopy of that or another copy of it. But there is an eligibility lookup tool by NPI. If you go to the QPP website, qpp.cms.gov, right on that front page, you'll see a check eligibility button. You can click there, put in your provider's individual NPI numbers, and it will then detail that information for you and let you know whether that provider, how that provider compares to that low volume threshold and whether they're a MIPS provider or not. Looking at reporting periods, under meaningful use, the new and returning participants, for the meaningful use measures, it is any continuous 90 to 365 days within the calendar year. So anywhere from 90 to the full year of reporting for the meaningful use measures would meet those measure requirements. And providers electing the optional stage 3, there is that option still available here in 2017 that you could elect to opt forward and move beyond the modified stage 2 requirements and start reporting on stage 3 instead. You would also get a continuous 90-day reporting period. That does require that you are up and running on your 2015 version of your certified EHR. So if you weren't already aware, you need to be working on an upgrade. That upgrade hopefully can happen for you sometime this year. As of right now, you need to be up and running on 2015 cert by January 1st. We'll see if the regulations change that at all. But as of today, you still need to be up and running on January 1st. So for returning participants, and this is for meaningful use only, CQMs must be reported for a full year. So this is the regulation as it stands today. This is a bit out of alignment with other programs and really everything we've seen thus far, but as it stands today, even though you have a 90-day meaningful use reporting period available to you for your meaningful use measures, your CQMs must be reported for a full year. There is a proposed rule that is out right now that is likely to change that later this year, as long as they finalize what they have proposed. That is likely to shift to if you are manually reporting your CQMs, you will still be stuck with a full year of reporting. Meaning if you are logging into CHAMPS and manually inputting your numerators and denominators for your CQMs, that's a manual attestation. If that is what you will be doing, you will be stuck with a full year of CQM reporting. However, if you are able to electronically report your CQMs, meaning you can download a QRDA3 file out of your EHR and upload that to CHAMPS, that would then allow you to report your CQMs, your quality measures. I just saw a question pop in asking me what a CQM is, because apparently I didn't put that on my acronym list. Sorry about that. CQM stands for Clinical Quality Measure. That is the quality measures that you are reporting on in both meaningful use and ACI. So if you are able to electronically report your eCQM or your CQMs into CHAMPS, you would be able to do a 90-day reporting. But again, that is only for eCQMs. That is not for manual attestation of CQMs. If you are intending to manually attest your quality measures into meaningful use, into CHAMPS, you will have to do a full year of CQM reporting. Under ACI or MIPS, we also have some options for your reporting period. We have something called the pick your pace options, which is what is detailed right now on this slide. We have the test pace, which is reporting just the basic. So under ACI, that would mean reporting on the 4 or 5 ACI base measures. And I'll talk about what the base measures are and the performance measures are as we get a little deeper into the slide deck. But you could accomplish the test pace requirements by simply reporting your 4 ACI base measures. And that would negate that payment penalty down the road for you. You can also submit for partial year or full year. And really the only difference between partial year and full year is that in a partial year you are somewhere less than 365 days of reporting. At least 90 days, anywhere from 90 to 364 means you're a partial year participant. Full year means you are submitting for the full year across the entire ACI category. So that not just the base measures, but your performance measures as well. And again, I'll talk about what the differences are in those measures in just a moment. Attestation options under meaningful use, there really is no option as far as how you get the data to CMS, or not to CMS, to Medicaid, and that is through CHAMPS. So you are logging into the CHAMPS system, going to the EHR MIP program, and doing a manual attestation there. That is the only option for attesting to meaningful use. ACI gives you some additional options. We have QCDRs, your Qualified Clinical Data Registries, and qualified registries. They are a third party that is taking your data and submitting it on your behalf. They're submitting that to CMS on your behalf. You can also report if your EHR has that capability, and it's supposed to as a certified product, but we know that's not always generally the case. But the EHRs should be able to submit your ACI data directly to CMS as well. And there is a new attestation portal that is coming. So similar to the registration and attestation system that we had under Medicare meaningful use, there is a similar manual attestation system coming for the MIPS program, and that will allow you to manually attest your ACI scores as well. I do not know when that will be live, obviously sometime this year, so that it's up and running and available to you guys for the attestation window, which for both programs will open up on January 1st of 2018. So as it stands right now, first-time meaningful users, meaning you have never attested, you have never achieved meaningful use before under the Medicaid program, you can attest now because you've got that 90-day reporting period, and you can do a 90 days of your quality measures as well. So those folks can get in and do your attestation already if you've already achieved the meaningful use measures for a 90-day period. Everyone else has to wait until next year, and it's due to that issue of the CQMs right now, that if things do change under meaningful use later this year, it's not going to necessarily be in time to get an early attestation in this calendar year. So most likely, whether those rules change or not for the CQMs or eCQMs, anyone who has already attested to Medicaid meaningful use will likely have to wait for that the kind of normal attestation window of January 1st, 2018 to March 1st of 2018. ACI, that is the only option. Nobody's attesting to MIPS until the first of the year, and we have a little bit longer attestation window right now of January 1st, 2018 to March 31st of 2018. And just please note, big bold red letters there, if you are participating in both of these programs, you must attest separately for each program. Attesting to one of them does not give you credit in the other program. They are separate parallel programs. Looking at program structure between modified stage 2, we have the 10 core measures, your 9 quality measures, and that equals meaningful use. That same proposed rule that's out could shift your, I don't know what it says, your quality measures. It could change down to 6. So they are trying to more align meaningful use and the ACI performance category, so they're more similar. More similar to the MIPS program, so this is one change that is likely to finalize. But as of right now, you still are on the hook for 9 quality measures for meaningful use. It is likely to be reduced down to 6 to match the MIPS program, but we'll have to wait and see. Program structure for ACI then, it is pretty different. And it's really the main difference here is just in scoring between the programs. There's a few other minor changes that I'll get to as we look at each of the measures individually. But under ACI, we have something called the base score, which makes up 50 points of your total ACI performance category score. Then we have the performance score, which makes up an additional 90 points, up to an additional 90 points for ACI. You can get some bonus points up to another 15 points built in if you are linking your ACI category and your improvement activities. If you're leveraging your EHR to achieve your improvement activities, it could give you some bonus points here. Also, if you are actively engaged with more than just MICR, any additional public health agencies or registries that you're actively engaged with, any specialized registries would potentially give you another 5 points here as well. All of those get added together to give you your composite score. To maximize the full 25 points that are available to you under this category, you need to earn at least 100 points. Quick math, you can see that there's 155 points that are available here under this category. So as you can see, you don't have to necessarily hit a home run to maximize the point category here in the ACI. Let's take a little bit deeper look into each one of these categories since the ACI structure is a little more complicated. We've got that base score, makes up those 50 points. This is really the only place where we still have an all or nothing component to the ACI. They've tried to build in a little more flexibility into the program than what we're used to under meaningful use. But this is really where you still have an all or nothing. So you have to do each of these. There are 2 measure sets here. Depending on whether you're looking at the ACI transition objectives or what we're going to call the regular objectives, labeled here as 2018 and beyond. The difference here is what technology you're on. So if you are still functioning on your 2014 version of your EHR, which the majority of you still are, you are in the 2017 ACI transition objectives. The only way you could opt into the what we'll call regular objectives is if you are on 2015 technology. That new version of your cert is bringing in some new functionality that is needed to be able to achieve the requirements under these new objectives that align with stage 3. So the transition objectives align with modified stage 2. And in this base score, you have to achieve all of these objectives in order to get the base points, those 50 points. It's an all or nothing. You're either getting 0 points under ACI, or you're going to get those the 50 points. So to achieve this, you have to do one of everything. So under the ERX measure, once you send one electronic prescription, you have achieved the requirements for that base score. Under Health Information Exchange, for one of your transitions of care, you have to electronically send that summary of care to the next provider of care. Once you have done it for one of those transitions of care, you have met the requirements for the base score. Security risk analysis, that is a yes-no measure. Either you did it or you did not. You have to be able to attest yes to it here for the base score. And provide patient access. This is the equivalent of measure 1 of the patient portal measure. So it's when you are providing that access to your patients. You have to provide that access to one of those unique patients that you see during your reporting period, and you have achieved the base score objectives. So do one of everything, and you get those 50 points. If you miss any one of those, you are getting a 0 across the entire ACI performance category. From there, we get the performance score. So in terms of meaningful use, again, this is one of the main differences between the programs, is meaningful use, as you know, has those thresholds. So in order to achieve that objective, you have to get 40% or 50% or maybe 80%, whatever that threshold is for that measure. That's not how ACI works. Under ACI, whatever your numerator and denominator is, that's going to translate into points for you. So in terms of the performance score, you take your numerator and denominator and convert it into points. And I'll show you how that converts here in the next slide. But as you can see, again, we've got those 2 measure sets. We have the ACI transition objectives, which are for those of you that are on 2014 technology. And the regular objectives are for anyone who is on 2015 technology. Although, interesting to note, even if you are on your 2015 technology, you can still opt and do the transition objectives instead. So nobody is forced this year yet to use the 2018 plus objectives as they're listed. But if you're on 2015 technology and you want to plow ahead and transition into those stage 3 requirements, you certainly can, and we encourage it. So you can see a couple of the measures here are worth 20 points instead of 10. There are 2 less measures for the transition objectives, so they've doubled the point value to compensate. So provide patient access. Again, that's the one that correlates to measure 1 of the patient portal measure under meaningful use. So under meaningful use, you had to get 50% of those patients access. Under this, there's no threshold. So whatever that numerator and denominator is, it's going to translate to points. And so really your goal is to get 100%. You want to get your numerator to match your denominator, because if you do, you're going to get the full 20 points here. So the better you do on those measures, the more points you get. So how do you convert that performance score into that percentage? You can look here. So you take your numerator and denominator, create the percentage, you get that performance rate, and then find where that falls here. So if you had 50 patients out of 100, you'd have a performance rate of 50%. Look on here, that would translate to 5 percentage points. I've got a very rudimentary example, scoring example at the bottom here. I've got a much more detailed one here in just a moment. But under this example, if the MIPS eligible clinician submits that numerator and denominator of 85 out of 100, that performance rate is 85%, and they'd earn 9 out of the 10 points for that particular measure. So a little bit deeper scoring example, kind of wrapping it all together. Again, we've got that base score of 50 points. You can get up to an additional 90 points for performance score. You can get some bonus points for additional public health registry reporting and aligning your improvement activities. So in this, and I've got an even better scoring example coming up as well. So if the MIPS clinician received that base score, so they did everything they needed to for that 50 points or 50%, they get a 40% performance score. So out of those 90 points, they're getting, not great, but doing okay. That's kind of, we'll call them a mediocre performer. They get 40% for the performance score and no bonus score. They'd earn a 90% advancing or an ACI performance score. When you multiply that times the weight, which is 25% in this first year, it's going to contribute 22.5 points to the overall MIPS final score. So even a mediocre performer here, getting only 40% of their 90 points for performance, is still getting what I would deem a pretty good ACI score. So out of the full 25 points available, they're still getting 22.5. So again, as you can see, with the variation here, you do not have to be a perfect meaningful user. You don't have to perform really, really well on these measures to still get a really good ACI score. So some of the main differences then between these programs: meaningful use is still measuring everybody on the clinical decision support and CPOE measures, but ACI is not using those measures. So that's two measures do not appear under ACI. I mentioned this already. There are no measure thresholds that need to be met under ACI, with the exception of the base score. That's still where you have to get a numerator of 1. So that's the only place where there's still that threshold, even though it's only 1. So each numerator, denominator, or yes, no, just converts into points under ACI. And then except for the electronic prescribing measure, there are no exclusions for ACI. So you must meet the base requirements, and then the ECs can elect on reporting for performance and bonus measures. So no exclusions except for ERX. So be aware of that. If you've been taking exclusions, let's say on the HIE measure under meaningful use, which I'll get to in just a moment as we take a little closer look at each of those measures. You might be claiming an exclusion to get around the HIE measure on meaningful use, but you are going to have to figure that out here to be able to score under MIPS. If you do not electronically send one of those summaries of care this year for your reporting period for MIPS, you are not going to get a base score, which means you are not going to get an ACI score. You're going to take a 0 there. So be aware there are no exclusions for ACI except for the ERX measure. So it's really one of the main differences then is in the scoring between the programs. Meaningful use is very much still a pass-fail. Either you've crossed every T and dotted every I and you are a meaningful user, or you did not and you are not. Under ACI, because they use that decile scoring, everything except for that pass-fail under base score, it's not, everything else just translates into points. So there's no thresholds to be met. So let's convert some meaningful use scores over to ACI. It's a good way to take a look at your past performance and kind of project how you're going to do under MIPS or under ACI in 2017. You can look at those past measures, pull your meaningful use reports for 2018, and just do the conversion to see what that would equate to under ACI. So under this base score example, under the ERX measure, this provider did very well. They're getting a 96% performance score. They only needed 1 in order to meet those base score objectives, so they've met those requirements. VDT, the patient portal, same thing. They're offering it to almost all of their patients, getting 99%, but again, for the base requirement, they only needed to get 1, so they get that base score. The summary of care measure, or HIE measure, they did okay. They got 25% of them off electronically. Again, only needed 1, so they got the base score, and they did their SRA. That's a yes, no. We're going to be doing those till the end of time, folks, so get used to it. Got to do it for the base score here. They did, so they get that full base score. So let me look at the performance score and see how they did. So taking some of those appear here, we see them on the base score, but like ERX and the VDT and the HIE, those all translate, or ERX does not. The other two translate into performance score. So looking at that same HIE performance, that 25%, they only needed 1 to hit the base score, but then how they did, their actual performance translates into points under performance. So they did 25%. If you look back at that grid from a few slides ago, you'll see that equates to 3 points. This is one of the measures that has double scoring. Again, if you recall, under the transition objectives, 2 of them are worth 20 points instead of 10. This is one of them that's doubled. So instead of 3 points, they'd get 6. VDT, the patient portal, again, this is the other one that appears in the base score as well as performance. So you needed to get 1 for the base score, but then whatever your numerator and denominator actually is converts into performance score. So again, they did very well. They got 99%, near perfect. That does translate to the full 10 points under the decile score. This is the other one that is worth up to 20 points, so we're going to double it, and this clinician is going to get a full 20 points there. As you can see, again, while meaningful use, you only had to hit maybe the 50% mark. The more you do, when you go beyond that 50%, it does equate to better points or a better performance score under ACI. So don't just shoot for that minimum threshold for meaningful use. You want to be shooting for perfection because it's going to translate to better scores under MIPS. VDT use, so the patient portal, this is the equivalent of measure 2. This is how many folks actually used the patient portal, logged in, and either viewed, downloaded, or transmitted their data. They got almost half. They got 43%. Translates to a decile score of 5 and that final score of 5. Patient education also did very well at 97%. Translates to the full 10 points or 10%. Med rec also doing very well at 92%. Also gives them a full 10 points. Secure messaging, this provider didn't do very well. They got very few secure messages out. Only 31 out of 432. Translates to 7% of those got a secure message. And that only gives them a decile score of 1. So they get 1 point for that one. And then MICR, they're actively engaged with the immunization registry here in Michigan. So that is a yes-no measure. You're either getting 0 points for no or 10 points for yes. This provider is actively engaged with MICR, so they get the 10 points. So out of the full performance score available, they're getting a 62. Bonus score example, so looking at, there's a couple of ways to get some bonuses here. So for going beyond the immunization registry and connecting to any additional registries, you can get up to an additional 5% or 5 points. This provider, I'm not sure which specialized registry, but let's say they connected to MITRE. Because they connected to Michigan's dental registry, they're getting some additional points here. And they did not link the improvement activities with their cert. They did not leverage their technology to achieve their improvement activities, so they're missing out on those on that 10% there. So they're only getting the 5% bonus score. So adding it all together, we get that 50% base score, a mediocre performance score of 62%, and then the bonus score of 5%. As you can see, they're still getting 117%, which tops this performance category, tops out at 100%. So when you hit that 100% or 100 points, you earn the full 25 points. So again, you see there's a lot of great variation in this, where you do not have to be a perfect performer, an exceptional performer, in order to get the full 25 points available under ACI. So even though this clinician only had a 62% on performance, they still got the full 25 points. All right, let's take a little bit deeper look at each of the measures. I'll compare and contrast the differences between the meaningful use measures and the ACI measures. There is not a lot of difference between them. The one difference I did already call out is the fact that measures 2 and 3 on this slide are not a part of ACI. They are for meaningful use only. ACI did not carry the CDS or CPOE measures forward. Other than that, all the rest of the measures exist in both programs. So under meaningful use, objective 1, your security risk analysis, protecting your patient health information. We have been doing this one now for several years. We will be doing them till the end of time. You have to either conduct or review a past security risk analysis in accordance with the requirements. That is a yes-no threshold. Either you did it or you did not, and if you did not, you are not a meaningful user. Under ACI, it is the same. So you have to conduct the security risk analysis under MIPS. It is exactly the same. The requirements are exactly the same. So when you've conducted a single SRA, it's 2 birds, 1 stone. You get credit under both programs for that single SRA. But you do have to do it also under ACI. It is part of that required base score. So if you do not complete your SRA, you cannot get any score whatsoever under ACI. It is not part of the performance score and not eligible for any kind of bonus under ACI either. Objective 2, clinical decision support. There is no equivalent ACI measure. Again, there are 2 components to the CDS measure under meaningful use. You are implementing 5 CDS interventions that are related to 4 or more of the quality measures at a relevant point in patient care for the entire reporting period. If You have to ensure that those CDS rules are enabled on day 1 of your 90-day period. And then measure 2, you have to ensure that you have enabled the drug-drug and drug allergy interaction checks for the entire reporting period as well. So drug-drug and drug allergy are really just CDS rules. They're just very specific ones. So really, you have to ensure that you have 7 CDS rules enabled right on day 1 of your reporting period, and you have to ensure that they are enabled for the entire reporting period. And again, there is no equivalent ACI measure here. Same thing for computerized provider order entry, or CPOE. There is no equivalent ACI measure. We've got 3 measures here under meaningful use. They are the same as what we were working with under modified stage 2 previously. So under measure 1, we've got more than 60% of those medication orders that are created by the EP during the reporting period are recorded using CPOE. And then measures 2 and 3 with laboratory and radiology orders are both at greater than 30%. So you have to ensure that greater than 30% of those are recorded using CPOE. There are exclusions for those, so any EP that writes fewer than 100 medication orders, fewer than 100 lab orders, or fewer than 100 radiology orders could claim exclusions for in each of those individual measures if exclusion applies. Objective 4, electronic prescribing. So again, same as what you guys did all last year under modified stage 2. More than 50% of all permissible prescriptions that are written by the provider are queried for a drug formulary, a very important part of this. You have to make sure that you've got a drug formulary turned on. So you're querying them against that formulary and then transmitting them electronically using your system. There is an exclusion for anyone that writes fewer than 100 medication orders during the reporting period, or if you don't have a pharmacy within reach. So for e-prescribing for ACI is a little bit different. While under meaningful use, you had to get that 50%. After you've done 1 under ACI, you've met the program requirements. Getting more than 1 doesn't buy you anything extra. The reason for that is because e-prescribing is under the base score requirements, but it is not under the performance score requirements. So under the base score, you have to get at least 1 permissible prescription that is queried against that drug formulary and transmitted electronically. And beyond that, you're still getting credit under meaningful use, and you have to get to that 50% mark. But you don't get anything extra when you do 2 or more under ACI. Once you've met the base score requirements, you have maxed out the potential for e-prescribing. This is the only measure as it stands today that has an exclusion under ACI. So they are allowing anyone who writes fewer than 100 permissible prescriptions during their 2017 performance period to, you could put in a null value and still get credit here. So this is giving, CMS knows that there are some providers out there that do not prescribe meds. A lot of the dentists do not. So this would allow a dentist to still perform under ACI and still achieve the base score, even though they do not write any permissible prescriptions. If you do have fewer than 100, you can certainly still report whatever your numerator and denominator is here, and you'd get the appropriate credit for it. But if you're truly at 0, you can attest 0 and still get your base score credit here. But this is the only measure under ACI, folks, that has an exclusion. None of the others have exclusions. So as I mentioned, this is part of the base score. It is not part of the performance score. So when you get 2, it doesn't help you anything beyond that. And there is no bonus score here under electronic prescribing. Health information exchange. So again, this is what we formerly known as the summary of care measure. You're generating that summary of care out of your EHR and then electronically transmitting it to that next provider of care. You have to have greater than 10% of those transitions of care sent electronically. And for anyone who transfers fewer than 100 patients to another provider of care can claim the exclusion on this one, much like we've seen each year going up to this point in meaningful use. Under ACI, the requirements are the same. You are generating that summary of care out of your EHR and electronically transmitting it to the next provider of care. This is part of the base score, so you have to do at least one of those electronically to get any kind of ACI score whatsoever. I mentioned that already, so if you've been bypassing this one as it stands today, you cannot bypass this one under and hope to achieve an ACI score. You have to send one of them electronically. This one is, however, part of the performance score. So once you get past that one for the base score, however many you do submit electronically or transmit electronically is going to feed into your performance score up to 20% or 20 points. So this one, you get a lot of bang for the buck. Objective 6, patient-specific education. As we've seen in previous years, we have to provide greater than 10% of your unique patients within the reporting period, some patient-specific education resources that are identified by your cert. There is an exclusion here that most folks cannot claim, as almost everyone has some sort of office visit during the reporting period. Under ACI, very similar. So it's the same requirement. The measure is exactly the same. Again, it's just the scoring that's a little bit different. This one is not part of the base score, so however you do in your performance score gets you up to 10 points. So there's no requirement here. You could choose to ignore this measure. You don't even have to report on this measure. Because it's not part of that base score, there's nothing saying that you have to report on patient electronic access. It's just that if you don't report a numerator and denominator, you're not going to get any performance score points. There's also no bonus score here. MedRec, under meaningful use, is performing that function for greater than 50% of all transitions of care. So these are the patients that are coming to you from another setting of care. You are getting your hands on the med list from that sending provider and reconciling that in your EHR. You got to do that for greater than 50% of your patients that are coming to you. And there is an exclusion if you were not the recipient of any transitions of care during the reporting period. Under ACI, again, this one's really optional for you. It is not part of the base score. The requirements are exactly the same, but there's no threshold that has to be met. So the more you do or the better you do, the better the performance score is. You can get up to 10 points for this one as well. But again, you could not report a numerator and denominator at all under ACI for MedRec, and you'd still be able to get your ACI score. So there's no requirement here. It is completely optional. Although if you're doing it, I don't know why you wouldn't report on it, because it's going to translate into performance score for you. Objective 8, the VDT, or Patient Electronic Access, or Patient Portal measure. We've got two measures here again. The measure 1 is the same as we've seen for the past few years, where you have to ensure that you are providing patient portal access to greater than 50% of all of the unique patients that are seen during your reporting period. Measure 2, last year you only had to get one patient to log into the patient portal, and you achieved measure 2. That is no longer the case. It is now back to greater than 5%. You have to be working on your patients, ensuring that they are using your patient portal. As they log in and start to use your patient portal, that will chip away at this 5% threshold. You have to get over that 5% mark in order to achieve measure 2. Under ACI, this is providing patient access. This is the equivalent of measure 1. This one's going to divide out into 2 slides. This is measure 1. Or again, this is that providing that access, the equivalent of the 50% measure, or measure 1 on meaningful use. This is part of that base score, so you have to do at least one to achieve the base score, but then however good you do, that all translates into performance score. So the more patients you get up to 20%. So again, this is that other measure where just shooting for that 50% for meaningful use, you could be hurting yourself under ACI. You would achieve meaningful use with that 50% mark, but you would only get 10 out of the 20 points for that. You only get half credit under your performance score. So ensure that you are offering that patient portal to 100% of your patients so that you can get the full 20 points here. So this is the next measure under the patient portal. This is the equivalent of measure 2 under meaningful use. This is the folks that are actually using your patient portal, that are ones that are viewing, downloading, or transmitting. You have to get that 5% mark under meaningful use. There is no threshold that has to be met under ACI. So it is not part of the base score, but however you do in that performance just translates into points up to 10%. Objective 9, secure electronic messaging. Again, this is one where last year you only had to send a single electronic message to one of your patients, and you got the measure credit under meaningful use. We are back to a percent threshold now in 2017, where you have to get more than 50% of your unique patients seen by the provider during the reporting period. You have to send that secure message using your technology. And there is an exclusion available. So under ACI again, this is another one where it's really optional. You don't have to report anything under ACI here, but the more you report, the better your performance score. So it is not part of that base score, which is what makes it sort of optional under ACI. And the better you do, the more percentage points you get, up to 10 points. And again, there is no exclusion for this measure, as with all the others except ERX. Objective 10, public health reporting under meaningful use. Last year we had something called alternate exclusions that gave most folks a pass on measures 2 and 3. Those do not exist in 2017. There are no alternate exclusions whatsoever in meaningful use in 2017. You can wipe that terminology from your mind. So under meaningful use this year, you have to attest to active engagement with 2 out of 3 of these measures, and you could count specialized registry twice. So you could onboard with 2 specialized registries to achieve the measure objective under meaningful use. So under measure 1, we've got the immunization registry reporting, MICR. We've got option 2, which is syndromic surveillance reporting, which is not an option for the vast majority of providers. Only urgent care providers are able to onboard with syndromic surveillance. So nobody else can onboard and attest yes to active engagement now. So only urgent care settings can opt into measure 2. And then you have measure 3, which is specialized registry reporting. There are a lot of options out there for specialized registries. You don't necessarily have to undergo an exhaustive search to find them, but you do have to ensure that you are testing yes to 2 out of the 3 measures here, or claiming the appropriate exclusions if they apply. Under ACI, public health is significantly watered down. So under meaningful use, you're forced to attest to additional public health registries. Under meaningful use, really the only public health registry that's sort of mandatory is the immunization registry reporting, and even that's optional. So under ACI, public health reporting, immunization registry is not part of the base score, but it is part of the performance score. So if you are actively engaged with MICR, you can attest yes and get the full 10 points. If you are not an immunizing provider, or you did not give any immunizations during that performance period, you would attest no and get 0. So as you can tell, providers that don't give immunizations are sort of hurt here. So they cannot achieve those 10 points. That is why they built so much variation, why there's 155 points built into the program, and you only have to get 100 in order to maximize your ACI score. One of those reasons is to build in this kind of flexibility so that a non-immunizing provider can still achieve the full 25 points under ACI, even though they would get a 0 under this particular measure. So anything beyond active engagement with the immunization registry, or MICR, gets you bonus points, and that's it. So it's up to 5%. You don't get an additional 5% for each specialized registry that you attest yes to beyond MICR. If you are actively engaged with the syndromic surveillance system, you get 5 percentage points, or 5 bonus points under public health reporting. Same thing under specialized registry reporting. It doesn't matter if you are actively engaged with 1 or 7 specialized registries. You don't get 5% or 5 points for each one. You get up to 5% total in bonus points here. So some concluding thoughts as we get to see a number of questions have come in. If you have any questions for me, I will be addressing those next, so please get them in. I'll answer as many of them as I can in the 10 minutes or so we have left. So concluding thoughts. They are very separate programs. Meaningful Use and ACI are separate, and participating in one does not give you credit for the other one. They are separate parallel programs that you have to attest to separately. So although separate, they are still very similar, as you just saw. The objectives are nearly identical, with different measure scoring. We do drop a lot of the all or nothing components as we move from Meaningful Use to ACI. We also lose all but one of those exclusions. So there are some subtle differences, but some of the main differences really come in the way that the different programs are scored. Meeting Meaningful Use, as we are working with providers to convert their Meaningful Use scores over to ACI, what we are seeing is that if you are meeting Medicaid Meaningful Use, you are likely getting a decent, if not max, ACI score. So most of the time, when we are converting a Medicaid Meaningful User over taking those 2016 scores and converting them to ACI, almost always we're getting a full 25 points with those. So if you meet the Meaningful Use objectives, you're very likely doing very, very well under ACI, getting the full 25 points, or maybe 23 or 24, but right up there, close to 25. So because of the way the ACI scoring just looks at your performance, converts all of that into points, the goal should no longer be just meeting those Meaningful Use thresholds. I already mentioned this once, but I want to stress it again. Because every numerator converts to points, you want to be shooting for perfection. You want to be getting as many of those numerators as possible so that you can ensure that you're getting that full ACI score. It will also allow you some of that variation. Let's say if you're getting 100% of your patients, your patient portal access, that's that measure that gives you up to 20 points. That would allow you to do really horribly on another measure. Let's say the HIE measure, which we know is very, very difficult for folks to achieve. You could perform really horribly. Just get the one that you had to do for your base score. Don't worry about the rest. And you could still, because you're doing so much better elsewhere under other ACI measures, you can easily get that full 25 points. So use the variation that's built into the program to help you and help your providers get that full 25 points. So don't just shoot for those Meaningful Use thresholds, but know that if you are achieving those Meaningful Use thresholds, you're very likely getting a full ACI score anyway. Got a bunch of resources for you here. The Quality Payment Program, CMS's Quality Payment Program, is at the top at qpp.cms.gov. Wealth of great information there, a lot of great resources, including all the specification sheets that I was just pulled a lot of that information from for the ACI measures. We also have the QPP Resource Center for the Midwest. If you have not already signed up or looked at that, it is a free resource that we are spearheading here at Altarum. I encourage you to go to that site and sign up. Any offices that have 15 or fewer clinicians will qualify for that free support. I highly recommend you jump on there right now and get signed up if you can. A lot of other great resources for you as well. And with that, we will move into questions. I see quite a few questions have come in as I've been talking. We'll get through as many of these as I can. Let me read through the first one here and make sure I can answer it. I hope that we are going to get to the ACI and IA reporting process. Does it go through the EMR for attestation? And if so, does that mean that practices not on EMR are not eligible and get a 0 for the ACI category? Great question. So we don't know a tremendous amount yet about the attestation process, especially the manual attestation process that CMS will be releasing for ACI and the improvement activities. We know that there's an attestation system coming that will allow that manual attestation, but we don't know what that process looks like. The site is not live yet. If you do not have certified technology, you can still participate in MIPS. But what that means is if you don't qualify for one of the kind of regular hardship exception reasons, meaning the reason you don't have an EHR is not because of something out of your control, you would just take a 0 for the ACI category. So you could still perform with your improvement activities. You could still report on your quality measures. There are options available to you there that don't require certified technology. So you could still report under MIPS. You would just take a 0 under ACI. I mentioned that one about the CQMs. Is clinical quality measure, some terminology change. Meaningful use calls them clinical quality measures. Under MIPS, they just call them quality measures. We're kind of shifting our terminology over, and clearly I need to update this deck and scrub CQM and just go with quality measure for everything. Someone is asking me to restate manually versus electronically reporting CQMs. How do you submit electronically? So in MIPS, or not in MIPS, in CHAMPS, in the eMIPS system. So when you are manually testing under meaningful use, when you log into CHAMPS, when you get to the part where you are submitting your quality measures to achieve meaningful use, you have the option to either manually enter your numerators and denominators for your quality measures, that's for the 9 that you're going to report on. You also have the ability to upload a file. So every certified EHR supposedly has the ability to generate what's called a QRDA3 file. That is, it's a standardized report that pulls all of the quality measure data out of your EHR. You can download that file from your EHR and upload it into CHAMPS when you get to that point when you're attesting. That means you are reporting eCQMs or electronic CQMs. If you are doing that, as long as the proposed rule that's out right now finalizes, that will mean a change in the regulation for you. For anyone that is manually entering your quality measures for meaningful use, for some reason that I fail to understand, CMS has set that regulation differently than other programs, or even what we've seen previously in meaningful use. For 2017, manual attestation of CQMs is going to mean you are forced into a full year of quality measure reporting to achieve meaningful use. So you'd have a 90-day reporting period for your meaningful use measures, but a 365 days of quality measures. So that is only if you are manually entering your CQMs into CHAMPS. If you are able to electronically report your CQMs into CHAMPS instead, meaning you are downloading that QRDA3 file and uploading it into CHAMPS, that would allow you to attest to only 90 days of CQMs instead of a full year. I hope that's clear. Somebody asked if I'm going to be sending out the slides to the participants. You can actually download them right now. For anyone that hasn't seen it, if you look in the handout section, there are 2 versions of the slides that I uploaded there. The full slide versions, and then the 3-slide handouts version is there if you prefer that. If you have 2015 certified technology, can you still choose to follow modified stage 2 measures without penalty? Yes. So under meaningful use, no matter if you're on 2014 or 2015, you can do the modified stage 2 objectives for meaningful use. Nobody is forced into the stage 3 objectives yet. That comes next year in 2018 unless CMS changes things. But as of right now, you will be forced into stage 3 in 2018. But regardless of whether you're on 14 or 15 technology this year, you can do the modified stage 2 objectives. I'm going to get to one more question, and I've got a hard stop here that I need to jump off. Let's see if I can get a quick one. And the rest of the questions you will get in email from me directly. If the practice is PCMH, are we excluded from meaningful use or MIPS? Meaningful use? No. PCMH does not give you a pass on meaningful use. But under MIPS, if you are a PCMH office, it doesn't exclude you from participating in MIPS, but it does give you, it automatically gives you the 15 points for the improvement activities category. So a little bit off topic here, but yeah. So PCMH under MIPS means that you get improvement activities automatically. You do not have to attest to any additional improvement activities. You automatically get those full 15 points. But PCMH does nothing for you in terms of meaningful use, does not change any of your requirements. All right, folks, I apologize I can't get to all of the questions. I will make sure that each of you get an individual email from me with the rest of the questions. I do need to drop off for the day. So thank you all very much for joining us today. I look forward to seeing you again soon, and have a great day.